It's really a pleasure to give you today an overview of what we understand about Parkinson's disease from a very specific point of view. That means from a mobility aspect. First of all, I'm Walter Metzler. I'm working in Kiel, at Kiel University and University Hospital. And I'm really proud to have very distinguished speakers today with us, and I will present them in a minute. So Mobilise-D or Mobilise is a very large, mainly European Union funded project that has the aim to develop and validate mobility algorithm that can take information out of one sensor at the lower back and give us an understanding of how people walk, how they move in their free environment. And this project focuses on specific diseases such as Parkinson's disease, and a lot of people are involved, as you see, and mainly on the left side of this slide. Concerning Parkinson's disease, which is the focus of this meeting today, we have 4 sites in the UK and in Europe that are investigating people with Parkinson's disease with this respect, and you see the contributors on the right side. That is Newcastle in UK, Erlangen and Kiel in Germany, Leuven in Belgium, and Tel Aviv in Israel. And we all are investigating a total of 600 people with Parkinson's disease over a course of the disease of 2 years. This is the disclaimer of the project, and now I want to give you a short overview of what we want to present today to you. That is, first, we want to give you insight into an individual situation of a person affected by Parkinson's disease, and I'm very happy to have you, Uli Funken, here on board, who is very experienced with the disease and is really helping a lot also with regard to research questions, is also in the advisory board, and is really a person that first of all understands a lot of Parkinson's disease, and second has also a speech that is understandable to anyone that is, for example, not affected by the disease, which is not self-explanatory. Thank you very much, Uli, that you will start with this webinar. Afterwards, we have 2 young scientists, Lisa Alcock and Jenny Kudelka, that will present the aspects of Parkinson's disease and its progression as we understand it from a clinical point of view and also from a movement scientist point of view, so that you also get a little bit an impression of how we think from a pathophysiological point of view, how mobility can be understood in such a disease. Then we move forward to treatment aspects of Parkinson's disease, and I'm also happy to have also very famous people here, Alice and Christian. Good to see you and to know that you will present treatment aspects, and we focus here very clearly on allied health aspects of the treatment of Parkinson's disease, and not so much on the pharmacological aspect, because this is also that aspects where you as a person that may be affected by Parkinson's or may have friends that may be affected or work in the professional area of Parkinson's, where you may make a major impact on how to deal with the disease. We will then close with 2 people from Kiel here. I'm happy to have you in, Marta and Corina, that have very practical experiences with the study design of Mobilise and how this study is performed, so that also people working in the research field of Parkinson's disease learn what are our experiences with the disease, what can be done better, but what also works very nicely. with these words, I want to close my introduction section and want to give you, Uli, the floor, and looking very forward to a very interactive and informative webinar.
So thanks very much for the introduction, and thanks very much for giving me the chance to share my personal journey with Parkinson's with you, which I call PD with the 10% chance of brain tumor. And I hope you find out during the course of the presentation why that is. So every journey has a beginning, or so you would think. So the problem with Parkinson's is you find out that very quickly that by the time you notice that something is wrong, about 80% of the damage has already been done. And that means a lot of the brain cells that produce dopamine in the back of your brain have already died away. So that's obviously unsatisfactory, but there's always to keep in mind. For me personally, my journey started in 2005, early January. I was on holiday with my wife, and I noticed that I couldn't move the fingers of my right hand as fluently as with my left hand. So that was kind of disturbing. My handwriting had always been bad, pretty much since primary school. So that couldn't have been it. So, but anyway, so with that started a long journey that, yeah, visit to the GP, blood test, urine samples, brain scans that I didn't even know that existed. And so for me personally, it took about 3 months to the diagnosis. For other people, it can be years and of misdiagnosis, uncertainty, and that's obviously very, very frustrating. At the end, then the consultant gave me his long speech, from which I don't remember much because I didn't really hear all that well because it was all a blur. But ultimately, he tried to give me some words of consolation. He said, yeah, first thing he said is, you're lucky because it could have been a brain tumor. And the second thing he says, and that was some consolation for me, he said, if he had to pick one neurological disease at the moment, if he had to pick, he'd pick Parkinson's because there's so much research in that field that that was probably the one he'd pick. The last thing he did is he sent me to another expert in the Parkinson's field for a second opinion, because I was, with 45, I was the youngest at the time that he'd ever seen with Parkinson's. And the good professor took one look at me and said, yeah, there's no doubt you have Parkinson's. I didn't need any of the scans and so on to confirm that. However, he still said that even with him, the accuracy of his diagnosis is only about 90%. So there come my 10% of brain tumor. So, so obviously the first thing I felt was shock, lots of questions. What now? Why me? Will I die with this? And you quickly find out that the internet is a very scary place. It's lots of unfiltered, unverified information. So I stayed away from that. And my good wife, she sort of sheltered me from that, and she did all the research, and she took the brunt of the confusion. But at some point, I think you got to come out of your shell and start sharing with friends and family and work. And you start realizing there's a support network out there with Cure Parkinson's, Parkinson's UK, and so on. And at some point, I was brave enough to visit a local support group. So for the first time, I was meeting people with Parkinson's like me. Now, they weren't really like me, and that's what the other thing you have to learn and accept very quickly, that nobody's really like you, because everybody has a personal experience with this disease. So the people I saw there may have been in a completely different phase of their illness. Yeah, I couldn't really predict as to how I would be like in in 20 years' time. So after a while, then new symptoms started creeping up. Loss of sense of taste and smell. I was part of a thesis of a neurologist in Romford, and she confirmed after a day worth of tests that I probably only have about 10% of the taste of smell and of the sense of taste and smell than any of you would have. So that was kind of an eye-opener. You start suffering some cognitive problems, maybe memory losses, lots of tiredness, fatigue, confusion, and mobility becomes more and more an issue. And with that, I mean, the dreaded freezing, where all of a sudden your feet give a stop and don't move forward, which is obviously a problem if you're in motion and you're already committed to your body and your feet don't want to take them forward. You most likely fall flat on your face. Shuffling, falling, walking upstairs and downstairs was an issue. Dyskinesia, which is involuntary movements. A lot of people suffer that, and unfortunately, it's also something that's brought on by some of the medication that we're taking. Mumbling of speech, which is very frustrating, especially to my wife, because half the time she don't understand what I'm saying. So hopefully you do. Things like dystonia, which is twisting. I always say I have the claw. So when I sit too long at the PC, my hand turns into a claw. So that's time for me to stop. As I said, no two persons with Parkinson's are the same. If you take two examples that I personally like, is you see Michael J. Fox. He was diagnosed with 31, and he was an actor, and he played. He was an actor. He was acting for another 20 years or so with the illness, and he sort of built, at least as I try to think so. He tried to build his movement issue into his role, into his character. But if you see him today, he's in constant movement because of his dystonia, dyskinesia. On the other hand, you look at somebody like Billy Connolly. Billy's act was, to me, always dominated by him pacing up and down the stage and laughing about his next joke. Now, if you see him now, unfortunately, he's still a lovely and funny gentleman, but he has what I call the Parkinson's face, the mask. He just has an unmoving face. The muscles don't work. He doesn't smile. He doesn't laugh. He doesn't cry. It's just a bit like a statue. So, okay. So yeah, you quickly find out that, and I did, that the new normal is pills, pills, and lots of pills. And so you sometimes feel a bit like a guinea pig, because you don't really know when and if you have the right, what the right doses and combination of medications is until you hit the sweet spot. It's a bit like Dr. House. Yeah, I'm not sure if you remember. I always was fascinated by them. They did diagnosis by trying to exclude everything else, and then it was lupus. So this whole thing takes likely years, not months, to find the right combination for you, especially keeping in mind that the progression of the illness also may change some of your medication. Most importantly, I find, is to recognize my day. During the course of the day, I really experience what everybody calls wearing off periods of my medication. And the key thing is to manage your day around that, so that that you can minimize the wearing off periods and make sure you don't overcommit during these times. Overall, I had to adjust my lifestyle, but staying active is one of the key things. It's a bit like use it or lose it. And don't let Parkinson's dominate your life, because yeah, as I said, I have Parkinson's, but it doesn't have me. My personal journey, coming back to that again, as I said, I was diagnosed in 2005, aged 45. Worked for another 10 years, and then I retired from work, which is seems to be typical. 10, 11 years, people continue to go to work, at least to some degree, and then they can't do it anymore. I started Tai Chi and cycling under the, as I said, stay active. Tai Chi is a good one because it teaches you balance and focus. Cycling I found very nurturing, and I managed to do a 6-week sponsored cycle ride along the river Danube in 2008, and we collected £5,000 in donations. I got a dog, keeps us on our toes. I joined the choir. Singing is very good to release substances that make you feel better. I also started going to medical trials, which helped me tremendously. So I didn't have this feeling of helplessness and uselessness. It gave me a sense of purpose. And finally, I moved to Cornwall, which is lovely. You see a picture of my house here, and I just pinch myself every morning when I get up that I live in such a place. So after 17 years now with Parkinson's, I consider myself lucky. I think PD has given me a number of opportunities that otherwise I would have never occurred to me, and I would have never been brave enough to pick up on. So with that, I'm at the end. So if you have any questions, please let me know.
Yes, Uli, this is a very deep insight into what is going on with a person with such a chronic disorder, and I'm really very grateful for your honest words, and also for presenting some issues and some problems that came with the disease, but also for ending with the positive aspects. And I think this is it has quite a philosophic touch, and very grateful for that.
Thank you. Pleasure.
And then we move to the next presentations. As I've already said, Jenny and Lisa will talk about the different phases of Parkinson's disease, and thank you both for presenting.
Yes, thank you, Walter, for the introduction, and I'm happy to give a quick overview on Parkinson's disease from a clinical angle. I work as a medical doctor in movement disorders, or researcher in the movement disorders field. So Parkinson's disease for me is part of my clinical work and also of my scientific work. I'd like to start with a brief overview. I think my slide is not moving, is it? Yes, now it is. In 1817, when James Parkinson published an essay on observations that he made on patients, but also on pedestrians on the street, which he called an essay on the shaking palsy. And the observations were a combination of symptoms he had seen in affected individuals, namely a tremor, a bent over posture, and a slow, small stepped gait. And even today, these symptoms are part of the typical clinical picture of Parkinson's disease, and the research of the following decades and centuries has found out a lot about the etiology of Parkinson's disease. For example, that the disease is based on the neurodegeneration of dopaminergic cells in the substantia nigra. Tremor, rigor, bradykinesia, and postural instability are the so-called cardinal symptoms of the disease, and for a clinical diagnosis of Parkinson's syndrome, as we call it, bradykinesia and at least one of the other symptoms must be present. In addition to those motor symptoms, non-motor symptoms can also play an important role in the quality of life of PD patients. Depending on the course of the disease, this can be, for example, symptoms such as constipation, bladder emptying disorders, REM sleep behavior disorders, or psychiatric symptoms such as depressed mood or PD dementia. And to talk a little bit about the phases of Parkinson's disease, it must be said that these motor symptoms can also occur before the motor symptoms, and that is before Parkinson's disease can even be diagnosed. Therefore, according to the latest findings, a distinction is made between the following phases of Parkinson's disease. First, there is a preclinical phase in which neurodegeneration has already started in the substantia nigra, but no clinical symptoms are present yet. And this phase is followed by the prodromal phase, in which various non-motor symptoms are already present, such as hyposmia, constipation, depressive symptoms, or REM sleep behavior disorders. And this phase can last up to 15 years. And at the onset of the motor symptoms, that is at time of diagnosis, approximately 50% of the neurons in the substantia nigra have already degenerated. The motor phase itself is usually classified into 5 different stages, which are based on the Hoehn and Yahr stages. From stage 1, which describes a unilateral disease, for example, a tremor of one hand, to stage 5, where patients can be bound to a wheelchair or bed. And those Hoehn and Yahr stages illustrate that mobility plays an important role, not only in the objective severity of the disease, but also in the patient's ability to cope with everyday life and independence. Another more small step measurement tool that we see here on the slide is the MDS-UPDRS, which is the Movement Disorder Society Revised Unified Parkinson's Disease Rating Scale. And that is part 3, the motor part. And we see some figures from a review on progression markers in Parkinson's disease, which show how the duration of the disease, with the duration of the disease, the Hoehn and Yahr stages, for example, in the left figure, and the MDS-UPDRS 3 score in the right figure increase in different cohorts from different studies. Which also complicates things further is that mobility in the course of the disease is influenced not only by the Parkinson's disease itself, but also by the side effects of years of dopaminergic medication. And at the beginning of the disease, as we see in the left figure, the medication has a quite satisfying effect on mobility, which can be achieved, for example, by 3 doses of levodopa a day. And then with the further duration of the dopaminergic medication, as we see in the middle and right figure, fluctuations in the effect can occur. And the duration of a positive effect of levodopa on the motor function becomes shorter. And moreover, fluctuations occur and are represented, for example, in on and off phases. And these phases can involve also other motor symptoms, such as dyskinesia, which is involuntary movement in the on phase. It can also occur in the off phase, and increased freezing, which means that the feet are sticking to the floor in the off phase. This is a quite complex situation that often leads to more difficulties in the medical treatment, and also to communication problems between doctors and patients about the symptoms. For example, dyskinesia is often not noticed by the patient themselves, sometimes therefore not reported in the consultation with the physician. Or another problem might be that dyskinesia and tremor can easily be confused. And this means that the physician only sees the patient for a short period of time. So the physician only sees a snapshot of the patient's daily life. And the snapshot also takes place in the clinic and not in the patient's usual environment. This means that, as those pictures are supposed to display, that the physician is left with their own judgment from the clinical examination, which can be quite short, and with the medical history with the patient and, for example, other subjective information such as movement diaries, which we can see in the middle picture, and are based on these things, a decision on the treatment can be made. And I think from these explanations, it becomes clear that there is a need for objective measurement tools for mobility, such as sensors, which are researched in the Mobilise-D study, to improve the diagnosis and also the therapy options for PD. And now I will move on to my colleague Lisa, who will continue at this point with more detailed information on gait alterations in Parkinson's disease.
Thank you, Jennifer. So over the next few slides, I'm predominantly going to focus on gait, the way that we walk in people with Parkinson's. So next slide, please, Jenny. So people with Parkinson's often demonstrate changes in the way that they walk compared to older adults of similar age and sex. Typically, a person with Parkinson's will walk with short, shuffling steps. They may walk with a stooped posture, such as the individual in the picture on the slide, as well as demonstrate reduced arm swing and display tremor. Gait impairment is further exacerbated in the presence of non-motor symptoms which affect people with Parkinson's, such as visual dysfunction, cognitive impairment, and gait impairment also influences the increased risk of falls in patients with Parkinson's disease. It's therefore incredibly important to measure gait in people with Parkinson's. There are an infinite number of ways or outcomes which we can measure to describe the way that somebody walks. So we may be interested in the overall walking speed of an individual, because walking speed has been proposed to represent a vital sign. So in the same way that we might measure blood pressure or heart rate in the hospital to determine overall health, measuring the speed at which we walk can inform us about longevity and important health outcomes. So Jenny is working through the slide there and showing you a more detailed approach that we can take to measure the way that somebody walks. And if we do this, what we can do is characterize the way that somebody walks by exploring stepping patterns. So for example, we might be interested in the temporal nature of our steps, the time it takes to take a single step, or the time that we spend with our feet in contact with the ground, which we've referred to as the stance phase, in comparison to how long we spend with our feet in the air, which is what we refer to as the swing phase. Alternatively, we might be interested in the spatial configuration of our steps, so the distance between our right and left feet, which we would refer to as step width, or how long each individual step is, or our step length. Another approach is to look across multiple consecutive steps to see how much variation there is from one step to another, which we refer to as gait variability. We may look to see if there is variation in the timing of our steps, so the temporal components, or equally if there's variation in the spatial configuration of our steps, so the spatial components which I've just reviewed. Particularly in the instance of evaluating gait in people with Parkinson's, we may also be interested in gait asymmetry. That is how much difference there is between the right and left steps. So if we can move on to the next slide, please, Jenny. Parkinson's disease, as we've already heard during this webinar, is very much a progressive condition with symptoms worsening over time despite optimal medication. Longitudinal studies of people with Parkinson's involving repeated measurements of gait have revealed which gait outcomes progress over time in line with progression in disease severity. So if we could click, please, Jenny. So collectively, these studies have shown that discrete outcomes change at different points during the and from these findings, it's possible to see that gait outcomes relating to the pace and rhythm with which we walk change early. So they change within the first 18 months after receiving a Parkinson's diagnosis. If you could click again. And as the disease progresses, we see different gait outcomes changing. In particular, we see increased gait variability after 3 years, which remains present up to 5 years post-diagnosis. Click again, please. Similarly, reduced gait asymmetry is observed 5 years post-diagnosis of Parkinson's disease, which is in line with symptoms becoming more bilateral with disease progression. If we can move on to the next slide, thank you. So levodopa is the mainstay of treatment for motor symptoms in people with Parkinson's disease, and a number of studies have evaluated which gait outcomes respond to levodopa treatment and which do not. Studies may assess people with Parkinson's disease whilst considered off medication, so after they've abstained from medication during the course of a night, and then assessed before that first matinal or morning dose of levodopa. They're then reassessed after the first evaluation, and differences between the way that somebody walks are evaluated. Alternatively, there are other approaches to look at which outcomes respond to levodopa in terms of the way that we walk. So sometimes studies may look at repeated gait assessments over a longitudinal time course and assess the relationship between changes in gait and mobility, and then changes in the dose of levodopa. So if we summarize these findings collectively, what we can see is that it's possible to manage some gait outcomes with levodopa. For example, gait speed, step length, and step time, or our cadence, are outcomes that respond to levodopa treatment. Conversely, gait variability, so how much one step varies to the next, and also dynamic stability during gait, are outcomes that are less responsive to levodopa and require alternative treatment therapies. Next slide, please. The Mobilise-D clinical validation study aims to validate digital mobility outcomes that may be measured using a small wearable device over the course of 7 days, whilst individuals continue about their usual activities at home. And we propose that these digital mobility outcomes may be used to identify individuals at risk of adverse clinical outcomes such as falls, a loss of independence and mobility, and hospitalization. Continuous monitoring of gait and mobility in the real world provides unique insights that cannot be obtained from a single visit or phone call. For example, obtaining insights over the course of a day could be used to inform clinicians about motor fluctuations or periods of ambulatory activity, such as the proportion of a day that an individual spends physically active or walking compared to the proportion of a day that an individual spends sedentary. Routinely monitoring gait and mobility over longer time periods, such as repeated assessments over many months and years, will ensure that clinicians and healthcare professionals can monitor and track changes without the need for multiple in-person clinic visits. This will be particularly helpful for patients who may not live in close proximity to the clinic or may have limited options for making travel arrangements, or for those individuals who have limited mobility. In addition, monitoring progression in this way will provide clinicians with insights that may be used to identify risk earlier. For example, identifying people with Parkinson's who might be at risk of falls, and consequently delivering personalized interventions earlier using preventative therapies. By using a wearable sensor, as depicted in the image on the slide, we may obtain insights from a patient whilst in their own habitual environment. Often it's challenging to gain a representative understanding of how a patient is actually doing during an isolated clinic visit. Often described as the white coat effect, patients typically perform at their best during a face-to-face clinic appointment, and therefore it's important to recognize the impact of environment and monitor patients in their home environment as well as during face-to-face evaluations. Developing a wearable solution to monitor gait and mobility in the real world ensures that everybody has an equal opportunity to access healthcare, and determining how mobility may be used to predict clinical events ensures that we're striving towards personalized medicine delivered in a timely and effective manner. So with that, we can move on to questions.
Lisa and Jenny, thank you very much. This was a very informative part of the webinar, and I don't see burning questions now in the chat, if I see it correctly. Yes, it's particularly interesting what you report, Lisa, about the situation of assessment of symptoms, and I think we cannot stress enough that we are seeing a movement in medicine that is going into direction digital medicine, and not only because we are performing such a project. We see it in many areas of medicine, and especially that assessment comes into the homes of those that are affected, because we believe that this data is much more relevant for understanding the disease and for treatment. Yeah, thank you very much. Then if no one else wants to comment, then we move to the third part.
I am Alice Nieuwboer from the KU Leuven in Belgium, working at the Department of Rehab Science, and I will do this presentation together with my colleague, Professor Christian Schlenstedt. So we will discuss the non-pharmacological trials that give indeed hope to actually improve mobility. And Christian will talk about how digital outcomes can play a role in improving those non-pharmacological trials. So could you move on, please, Mara? Yes, so I'm just, I know that you've all had some background about Parkinson's disease, but I want to come to the essence with respect to designing non-pharmacological trials. So dopamine depletion in the brain brings on reduced modulation of movement vigor. Not only that, but it also affects the automaticity with which we can move. So we have to think more about our movements. And that is what you see on this slide. You see that in the middle, there is a dark spot in the brain, and that's where the dopamine depletion actually causes dysfunction. And around that, you see cognitive and sensory areas that actually help us to compensate for the dysfunction in the motor circuit. Okay, could you press on, please? So having this problem with motor vigor and automaticity makes it more difficult not only to deliver exercise, but also to conduct exercises. Just imagine that when you are thinking about starting exercise as a healthy person, and then think that it must be even more difficult to do it when you have the brake on your movements from Parkinson's disease. So the compromised motor system makes exercise delivery and capacity more difficult. Not only that, but also the transfer of exercise effects to daily life is also affected, because the disease unfortunately affects also the ability for us to retain what we've learned in terms of our training. So let us look at the evidence on exercise effects to date. Could you move on, please? So this is a very good picture that comes from a recent review on exercise. And could you also move on one more time? Yes, so neurologists these days actually advise patients to definitely go for exercise, and with good reason. You see here this seesaw, and on the one hand, on the left hand, you see all the benefits in blue, and the strongest benefits at this point in time affect physical fitness of patients with Parkinson's disease, and also reduce the motor scores in Parkinson's disease on a scale which is called the MDS-UPDRS, but it actually means that the severity of motor symptoms gets better. So we actually have very strong evidence to support this. In the lighter blue colors, there are a number of issues where there is good reason to think that exercise is helpful, but the evidence is less strong. And also at the moment, we don't really know whether exercise affects disease modification. But of course, we always have to think about both sides of the seesaw. So there's also on the red side, there are some possible issues with exercise as well. Some patients can experience some cardiovascular complications. It may increase falls, And compliance is something that is a real issue. And please, could you move on there? That is, I think, central. The better the compliance is, the more effects we can expect from exercise. So could we move on to the next slide? And also again, please, could you press again? Yes, thank you. So I'm going to look at two very recent studies on exercise, which have something in common, namely that both studies addressed exercise that was undertaken for 6 months. So that's a really nice long period. And both of the studies were also targeted to improve fitness of patients, meaning it was endurance training. And this particular study was delivered in the Netherlands, whereby patients were offered cycling in their homes. So an ergometer was placed in the home. Patients had to exercise for 6 months. And you can see also that the cycle was enhanced with some digitized instruments. And that is something that we see more and more in the exercise literature, that digitized instruments help exercise delivery. Could you please move on as well? Yes, so the exercise group received cycling, whereas on the other side, there was an active control group that only did stretching exercises in the home situation. And this was delivered in sedentary patients in the early stages of the disease. Could we look at the next slide, please? So what this study found was quite spectacularly that patients that were doing the cycling actually had a really nice stable UPDRS motor symptoms, unless on the right-hand side, the stretching exercise group that actually deteriorated. And the difference between the two groups was significant and included also a meaningful effect, but this effect was mostly seen in the off-medication stage. Also on the right-hand side, you see that patients increased their fitness, as you can see here in green, by the VO2 max, which is a parameter showing better fitness, unlike the stretching group. Could you click, please, Mara? But there was no transfer of these positive effects of exercise to gait, balance, and ADL, activities of daily living measures, as measured with classical motor capacity tests. Now, when we look at compliance, could you move on, Mara? Yes, the compliance was, there were quite a few patients who did very well in terms of exercise compliance, and they had, after all, the exercise instruments in the home situation, but 21% also displayed poor compliance, and dropout was also very much present in both exercise groups. So let's move on to the second exercise study, which is the brisk walking study. And that was conducted in Hong Kong. Also for 6 months, patients were walking in the first 6 weeks of this study in the exercise groups on the left-hand side. Patients were having a supervised training and then trained on their own. And again, they used a digitized help with this wristwatch, by which they could look at whether their brisk walking was actually improving their heart rate. And during that unsupervised session, they still got messages from physiotherapists. This exercise group was contrasted with an active exercise group that only received exercises for their upper limbs, such as writing training. Could we then move on to the next? Yes. So again, similarly as before, in the UPDRS motor scores, you see that the brisk walking group reduced their motor scores, meaning it was better, much more so than the active control group. And also the 6-minute walking test improved so much more in the brisk walking group compared to the sitting group. So let's look at the transfer. Could you move on, Mara? So here there was transfer to gait speed and balance tests, and compliance was also quite good, but here we had a larger group with poor compliance than in the previous study. So concluding then, Mara, could you bring up the conclusion? Yes, so high intensity endurance exercise that is maintained for 6 months is effective in early to mid-stage Parkinson's disease. Now the next slide, please. We bring this now into a bigger picture of endurance training. And when we look at all the recent studies that were compiled here in this systematic review, you see that when you look at all the details of the endurance training, very many different types of exercise were delivered in this category of exercise. And also, Mara, could you move on, please? Endurance training was, when we look at this overview of all these studies, we see at the bottom of this slide that indeed endurance training is effective also on medication, but could you move on, Mara? In red, you see that the endurance training that was high dose seemed to have greater effects, although when this was statistically analyzed in depth, this didn't come out as a significant effect. So we don't really know at this point in time very firmly what the dose-response relationship is. Neither do we know what the long-term effects are of this endurance training. And could you move on, Mara? So this was only looking at one class of exercise, endurance training, but of course there are many different types of exercises as well, which we need to consider. Could you move on? And here we see a long list of different types of exercises, which I won't go, all mention to you, but here in the colored squares, orange, light green, and dark green, you see the difference in effect sizes of these different types of exercise classes. And what is very apparent is that, of course, in different outcomes, you see different effect sizes. So this still gives a very varied picture, whereby it is clear that we still don't know which particular type of exercise we have to deliver and give and provide for different patients. So next slide, please. Yeah, one important thing is, just to come back to that last slide, is that what we really need is a common ground outcome through which we can compare these different types of exercises much better, rather than looking at this broad picture of all these different outcomes. Okay, next slide, please. So finally, a word or two about exercise for falls, because of course, here, falling is the most important risk factor for patients with Parkinson's disease. And here we have some good news coming out of an overview of all the different studies that are listed here that really tried to improve with exercise fall risk. And here we're looking at fall rates as an outcome that were summarized in this Cochrane review that came out in 2022. And what you see here again is good news about exercise, namely that exercise can lead to a reduction of fall rates with 26%, which is really nice, and also with moderate certainty of the evidence. And you even see that the amount of fallers are reduced as a result of exercise as well. So that is the positive news of this slide. Could you move on, Mara? But we have to take into account that most of these studies pertained to mild to moderate disease patients who had minimal cognitive decline and relatively low fall risk. And that brings me to the next slide. So in the same review, there was a sub-analysis done in 3 studies that actually could compare between high disease severity participants and low disease severity participants. And could you click twice, Mara? So what you see here is in red that patients with a lower disease severity were benefiting from exercise to reduce their fall risk, but it was not significant. And in green, you see not such a good message, namely that with patients with higher disease severity, exercise could actually be unfavorable and lead to more falls. So how do we interpret that? And the authors of this Cochrane review actually projected that maybe when patients with an advanced disease have less fear of falling and become more mobile, maybe they are exposed to a higher fall risk. So this really is a very important message that we don't understand yet, and for which it is so important to really look at their mobility data to get a better understanding of this. And this is my last slide, some reflections on exercise and training in Parkinson's disease and where we stand now. So clearly exercise has positive effects on multiple outcomes, but mostly on fitness in early disease and also into fall risk. However, we lack data on the impact on daily life performance and how exercise effects project onto ADL function. We lack data on the dose-response relationship of exercise, and if that is the case, then it is also more difficult to precisely deliver on exercise interventions and understand the mechanism of exercise. And finally, we really need accurate data on compliance so that we also understand that relationship and understand how the mechanism of exercise may actually be thought about in more detail. So now it's up to my colleague to talk about how digitized outcomes might fill in some of these lacunas that we have at this point in time.
Yes, thank you, Alice. My name is Christian Schlenstedt. I'm working as a professor for sports sciences and neurorehabilitation in Hamburg at the medical school, and I'm co-coordinator of the clinical validation study in Kiel. And I'm going to discuss whether the challenges and the gaps in the knowledge, which Alice Newberg nicely introduced in the previous talk, may be solved by digital mobility outcomes. On the next slide, I brought the definition of mobility, which is the subject's ability to move in his or her environment, focused on gait, balance, and transfers in order to accomplish functional tasks of everyday living. And there's another definition which says that a person's physiological ability to move independently and safely in a variety of environments in order to accomplish functional activities or tasks, and to participate in the activities of daily living at home, at work, and in the community. I want to highlight two things here. One is that per definition, mobility contains a variety of different aspects, which is, for example, gait, balance, and transfer. And second, per definition, the aspect of participation in activities of daily living and a variety of environments is really important when we speak about mobility. So in order to obtain ecologically valid data, and in order to follow this definition, of course, we need to collect data from the home environment. And that data obtained from the home environment differ from data which we can collect in the lab or in the clinic, is nicely shown on the next slide. This is a study which was conducted by Walter Metzler and his team. And here you can see that for the supervised condition, which is, for example, the assessment of a patient in the lab or in the clinic, we get different results than the unsupervised assessment, which can be, for example, in the home environment. For gait speed, for example, we see 30% reduced gait speed for the unsupervised condition compared to the supervised condition. But for other outcomes like and of turn angular velocity, we see in about 180% increase in the velocity in the home environment compared to the lab environment. Another thing we see here is that for step time, for example, there is an increase in step time in the unsupervised versus supervised condition, but for people with Parkinson's disease, what you can see in the upper part, but for patients with multiple sclerosis, there is a reduction in step time under unsupervised conditions. So the second thing you see here is that we get disease-specific information, and of course we need Parkinson-specific information when we speak about digital mobility outcomes. On the next slide, I'm going to talk about the responsiveness of digital mobility outcomes. This is also a very important aspect especially when we speak about exercise intervention studies, where the effect sizes usually are a bit smaller. So we don't know yet, and we don't have clear information about the responsiveness of digital mobility outcomes. But what you can see here in this figure, this shows the effect of levodopa on various digital mobility outcomes. And you see strong effects for some of these outcomes, especially for gait. Some other outcomes show fewer effects, and some of them even negative effects. But for gait, you can see these are the upper blue bars. You can see quite strong effects, which are higher than compared to the PIGD, which is the gray bar, which is the postural instability and gait difficulty subscore. So in clinical assessment by subscores of the MDS-UPDRS. And this is quite promising that digital mobility outcomes addressing and targeting aspects of gait might be promising outcomes and might be responsive. On the next slide, I'm going to talk about the responsiveness with regard to exercise interventions. And in this study, about 130 patients with de novo Parkinson's disease, so not yet treated by anti-Parkinsonian medications, were included and randomized to a high intensity exercise training group, a moderate intensity exercise group, and a usual care group. And the intervention groups, the two, performed treadmill training with different intensities 4 times per week over, again, a really long period with 6 months. And the authors of the study also collected data about mobility in the home environment, specifically number of steps per day. And you can see here that within the group of high intensity training, the number of steps per day slightly increased after the 6 months of training. And there was a decrease in the number of steps for the moderate intensity group and the usual care group. And this interaction, unfortunately, was not significant. And there are still open questions. So why was it not significant? Maybe the choice of this digital mobility outcome was not the best, or maybe those patients who were just mildly affected by the disease may have been already still too active. On the next slide, this is a study which investigated highly challenging balance training in people with Parkinson's disease. And here again, the authors collected information in the home environment, again, number of steps. And if you press Mara, there are steps per day, and you see an increase in the number of steps per day by about 6% for the training group, and a decrease by about 12% for the control group. And this interaction was significant. So these are promising results. As you can see here, that there are digital mobility outcomes like number of steps per day, which are sensitive to treatment. And but of course, there's still a few open questions. And one is, which you can see on the next slide, the question about clinical relevance. Of course, we need to know whether the significant changes we sometimes find in the intervention studies, whether these are clinical relevant for the patients, so whether they really whether these effects really impact the life of the patients. So I want to summarize on the final slide the question: can non-pharmacological trials benefit from digital outcomes to assess mobility? Although there are still open questions, generally I would respond to this question with a yes, because digital outcomes can be ecologically valid. And this is what we have heard, of course, in the talk by Alice, that we don't know much about the impact of exercise on daily living, because most of the exercise studies are testing in the lab, and this gap of knowledge can be solved by the use of DMOs. And further, we can have, of course, useful and very important information about the compliance. So we don't know very well what the patients are doing at home, especially for the home-based exercise interventions, and the use of wearable devices and the use of digital mobility outcomes can provide useful information about the compliance. Further, we don't know yet whether they are more sensitive, but if so, the mechanisms of different exercise types and also dose-response relationships can be better investigated by the use of DMOs. And next point, clinically meaningful findings may be provided by DMOs if we get and if we investigate information about clinically meaningful changes. Finally, DMOs might be less time-consuming and less expensive. Thank you for your attention, and I'm looking forward also for questions.
Thank you very much also for your presentations, Alice and Christian. Very exhaustive, very interesting points. I think it also shows that there are some paradigm shifts not only in the assessment of these diseases, but also in the treatment. And I'm impressed also by what you tell us about so minimal clinical or minimal relevant change, minimal relevant difference between assessments, so that this comes now more into the focus of these trials. You're also talking a lot about individualization and precision medicine aspects. So we have precision medicine aspects not only in the treatment aspects, but also in the assessment panels that we have to consider. And I think also presenting different phases lead to different outcomes is maybe not super entirely new, but it learns us also that we have to clearly define our concepts of interest when we investigate such outcomes. Maybe a question to Alice from the chat. Maybe you have seen it.
Yes, it's a very relevant question, and I would like to know the answer to that as well. So basically, we don't know the information that you're asking for, namely, you are projecting that maybe the falls in higher disease severity populations could have maybe been happening during home-based exercise intervention itself. Literally, we don't know the answer to that. I would project that falls usually happen in spontaneous situations in daily life, and less so during very targeted activities. I would also project that the therapists that were involved in some of the studies, particularly one study that was quoted in this systematic review on looking at high versus low severity disease patients, one study, certainly the home exercise that was provided was targeted and prescribed by therapists. And I would have imagined that fall risk would have been high on their list in the type of exercise that they would have projected to the patients. So I would think that it's probably not during the actual exercises that patients fell, but we don't know the answer to that.
Thank you very much, Alice. I see that it has sufficiently answered the question. Maybe Christian, could you comment now on a question that has been posed in the question and answer part of the Zoom here?
Yes, sure.
Yeah.
So there was a comment, which is Dr. Google can be a very scary source of information. However, the internet can also be an extremely valuable source of information. One must use trusted sources and double verify from yet another trusted source that provides the same information. I just have a comment because we did a systematic review of German-speaking web pages about Parkinson's disease a couple of time ago, and I can just confirm this comment which was posted here, that we found really some very nice and high quality web pages, but also some which were just confusing for the patients. And we summarized this information and we made a flyer which had two aims. One was to help patients find reliable sources of information and web pages for Parkinson's disease in the internet. And then we had a special focus on exercise. So we wanted to provide information which exercise and whether there are information about exercises in the web for people with Parkinson's disease. And yeah, but it was of course it was, or not of course, but it was for German speaking web pages.
Thank you very much, Christian. So it does seem to make sense to look after reliable information in the internet. It is not an easy task, but it is existing such information. That is very good news. Thank you very much, you both, Alice and Christian. And then we move to the last part. It is also the shortest part. And thank you very much, Corina and Marta, for giving us a little bit an insight into in daily life business, how these studies look like. Thank you very much.
Yes, we will talk a little bit on other topics, the practical experiences of the study team dealing with Mobilise-D. So first of all, how did we recruitment? How did we address participants, for possible participants for making part of the Mobilise-D study? So we had different strategies. First of all, we addressed patients on the ward and in the outpatient clinics. We had also patients that had already given beforehand consent to be contacted for further studies related to their disease. We had reached out to medical practices. We had contacted self-help groups and other patients groups, such as specific sport groups that were founded for specific disease groups, in this case, Parkinson's disease. We also used the internet. We posted on Facebook, and we had flyers displayed in well-frequented places, also in supermarkets, for example. And how did we do that? Yeah, we went on the ward and addressed the patients personally, or we contacted them by telephone, or also by sending out personal letters. In medical practices, we displayed information in form of flyers, or we asked the medical doctors to address patients directly and asking them if they were interested to taking part in a Mobilise-D study. In patients groups, yeah, the study team was searching for addresses of patient groups or self-help groups, and we addressed them directly, and they spread the information during their members. How successful was this strategy? As you can see, I've highlighted I've kind of flagged the information in green, green or red. So the direct contact in clinics was mostly successful, also because our medical doctors already knew the participants, they knew the medical doctors, the team, and of course the participants that have already had given consent to be contacted for studies, they also were already in touch with our clinic. Then they knew our team, so they mostly were willing to take part in Mobilise-D study. Whereas in medical practices, and also the sending out of flyers and posts was not so effective. I think possibly because it was more anonymous and patients were not addressed directly, and they hadn't signaled to be interested in study groups before. Patient groups were also highly motivated to take part in Mobilise study. Yeah, I hand over now to Marta that will give information about general experience from study staff. She was more in direct contact with participants.
Thank you, Karina. Yeah, so the general feedback is absolutely positive from the participants. There were really high interested in the study, even if participants in the end didn't take part in the study because of different things, sometimes even our own exclusion criteria. And even when we had sometimes to convince some kind of the participants in the beginning, we recognized that with every further visit, their interest was even bigger. And yeah, I think one main point was that the new thing in Mobilise-D is that we take a look in their real life at home, and that's happening with the sensor we give them. And that's new for all the participants. So far, they know the procedures in studies with a lot of questionnaires, which are also included in Mobilise-D, but the really new thing is the sensor, and they can wear it very easily without interrupting anything they're doing at home. And I think that led to the most interesting part for the participants themselves. And as the study team itself, it was very exciting for us to see how such a large study throughout whole Europe is working, and being there from all the beginnings and solving problems, mistakes in such a great and very, very huge team was very exciting. Yeah. About the assessments themselves, yeah, sure, it was pretty often sometimes very challenging to deal with all the participants, very individual with their diseases and their health condition in general, but all the individual limitations and problems they had. So the main things were the motor limitations and the language limitations. And that led sometimes to a pretty long visit over 3, 4, sometimes 5 to 6 hours. So we had to react in that moment and made sometimes 2, 3 to 4 or 5 breaks just to give them a little time to get new brief, try to keep them motivated as best as we can do, and keep their concentration high. But sometimes it wasn't possible to do it at a complete session on one day. So there was also the opportunity which we had to use to switch from a total clinical visit to a hybrid visit. And so there were sometimes some questionnaires that we finished on the next day on a phone call with the participants. Yeah. The feedback we recognized was given from the participants sometimes was that especially the ones with minor symptoms were sometimes nearly bored by all these questionnaires we are asking. On the other side, there were a lot of participants that were surprised by the questions we were asking. As written, sometimes participants said, wow, that's exactly what I experience at home, but they sometimes didn't even know that there's some kind of correlation with their disease. And the symptoms, they didn't know that they can be affected by their disease. And a third point that was also in the beginning pretty common, actually, that some participants, because we were asking a lot of questions and a really huge battery of possible symptoms that can occur with the disease. So some participants even got a little bit, some kind of afraid that these can happen to them in the future, and we had to calm them a little bit. But I think even that was, yeah, getting their interest higher, because they didn't know a lot of things so far about their own disease, because as already Uli in the beginning said, it is absolutely individual, or maybe it's very, very individual for each patient. Yeah, and the last point, some issues we came across during the study so far were some technical issues and some minor things with the sensor itself. We collect the data by asking a lot of questions. We do some measurements during the visit, and we have the 7-day measurement after that at home with the sensor. And we collect data also using by enter the data on tablets. And participants have to do some of the questionnaires for themselves using the tablets. That worked actually really fine. I was sometimes very surprised how well that worked. Besides that, we had with the tablets some kind of problem that the data was continuously uploading to a server, and that sometimes wasn't that as fast as we would wish to have it. And some minor problems we had with the sensors itself was during configuring the devices, not for the measurements in the clinic during the visit, but more often for preparing the sensor for the 7-day measurements for the home visit, for the home measurement. But that were still all things we could solve, and there are every measurement could have been done and finished. Since the beginning of the study, we recognized that there are still some things that, of course, can be are still in progress and can be progressed in the next months, years in future for other studies. Because I think we are still in the beginning of such a digital research. In that point, some minor things like the battery of the sensor, we recognized it's getting less by time, or something that the sensor that is worn with a belt can be worn the wrong way, top side down or inside out. Even when we give a lot of information and information sheets with the participants to their home, there's still some things that can be made in a better way. But still, the feedback of the participants was really amazing, positive.
Okay, I take over again from you, Marta. Thank you. I will talk a little bit about administrational issues, because during the study, we asked participants to send back the devices after the wearing period at home, and they were also asked to fill in diaries and send them back. And in the beginning of the study, this worked quite well, and we get everything back. And the longer the study lasts, the more difficult it is to motivate participants to fill in the diaries and to send everything back complete. Sometimes the belt is missing or the diaries are missing. And it's just to decide how to manage these things. We try to call participants at first, but then we recognize that they get bored when we were always calling. They already said, oh, you're calling again. So, but I think it's some of the participants perhaps were not aware that that the study lasts quite long. It's not a lot of burden, but yeah, they have always to keep on track and to fill in the diaries. So yeah, we recognize that's a little bit an issue. I have one last slide. With our initial question was, why are initiatives like Mobilise-D important for people with Parkinson's disease? Yes, as we had talked about, participants are really interested in such kind of studies because they open opportunities to really address their daily life impairments. And yeah, I think they are also, yeah, they are kind of, yes, the daily life problems are addressed with questionnaires, with diaries, and they are really on a very accurate point of their disease, of their individual point of disease. And I think that's what makes Mobilise-D really interesting for taking part in it for participants. Yeah, I hand over again to Walter. I will stop here. Thank you.
Thank you very much, Martha and Corina, for giving us this direct day-to-day insight. And maybe we can finish with such a round, and maybe we can go one slide back with this question I want to pose to everyone who has presented today. Unless no one from the audience has any questions, then please raise your hand and we try to answer as good as we can. Then Uli, what is your impression? How can this question be answered most accurately?
I mean, I said in my presentation earlier, I think staying active is important for people with power illness. So you have to use it or lose it.
Thank you very much. Alice?
Yeah, I'm coming from a study that we did on self-monitoring of physical activity in patients using activity monitors that were bought off the shelf and they didn't work. So the importance to me from Mobilise-D is to make sure that we have devices and algorithms that are credible for patients.
Thank you. Jenny?
I think that my main point is that studies like Mobilise can help to gather information about mobility in the home environment and over a longer period of time, and therefore provide a lot of information that can help patients and doctors in the long way to make more individualized treatment decisions.
Lisa?
For me, Mobilise-D offers the opportunity for us to be able to revolutionize healthcare in the future by optimizing therapeutic strategies so that we can identify those at risk earlier and identify and intervene in a timely and effective manner.
And Christian?
For me, maybe from a statistical point of view, it's just a really large sample size of 600 patients with PD who are followed over this period of time, which will allow addressing and responding to research questions, which we are usually not able to address with smaller sample sizes. And these are going to improve the treatment of people with Parkinson's disease in the long term.
So thank you very much, all the presenters again. Thank you also to the audience for staying with us. I think this was now a very nice summary, these last responses to what we think, what we can achieve with such studies for diseases such as Parkinson's disease. Thank you again. Have a good afternoon. Bye-bye. Hope to see you soon.